right, so hello, the few people here and several people online, hopefully. So this is going to be a whirlwind of kind of basic congenital heart disease stuff in newborns. And then I realized this was a OB/newborn conference, so I did include a few prenatal things as well. I do not have any disclosures. This is me and my family. We really enjoyed Chattanooga. We've been here the last 3 years. We have 2.5 little girls, all that get along well most of the time. But yeah, we've really enjoyed it here. So learning objectives, we're going to identify some basic congenital heart lesions and some more complex ones. We're going to understand the treatment and stabilization rationale for congenital heart disease and recognize appropriate cardiology referrals, both pre and post delivery. So normal circulation, most of you should know. So normal deoxygenated blood comes from the body to begin with. So from the head and neck and from the lower body into the right atrium here. Goes from an atrium to a ventricle via the tricuspid valve, then goes out to the lungs via the pulmonary valve. Blood gets oxygen, comes back to the left side of the heart through usually 4 pulmonary veins, goes to a left atrium, to a left ventricle, and then out to the body through the aortic valve and aorta, and then round and round it goes. And then we'll talk about all the variations to normal that we can have. Fetal circulation is slightly different. So before birth, you have a couple different defects. One is a PFO, and so that allows a right to left shunt across the atrium. Then you also have a ductus, or it's always a P, it was the Ductus Arteriosus as a fetus. Both of those essentially provide right to left flow and essentially skip the lungs because you're not really using them much before delivery. As we know, both of these things can persist, especially in preterm infants, but we'll talk more about that. So other things before birth. So prenatal diagnosis, OB ultrasound is definitely not perfect, and even fetal echo is not perfect, but we're getting there. It is certainly better at some lesions than others, and there is decreased accuracy in extracardiac things. So things like coarctation of the aorta is really tough, and then pulmonary vein abnormalities are really hard prenatally. And then complex anatomy, where there's just lots of different things in the plumbing, is sometimes hard to get exactly right prenatally as well. So there are some good studies about variations in heart disease and then the variations in diagnosis in congenital heart disease as well. This was a good 2015 article. They looked at 31,000 patients with congenital heart surgery at less than 6 months. And this was 2006 to 2012, so not that long ago, despite how not great we are about diagnosing prenatal heart disease. So the white bars are neonates, the black bars are infants that needed heart surgery. The lower ones are lower percentage prenatally diagnosed, as you might expect for older kids. You're just recognizing them later. But still at the higher end, at the end of this study, it was still 50%-ish, so still not great. And the diagnosis varies quite a bit by which one you're looking at. So the better ones are down here. So a hypoplastic left heart or a single ventricle, those are relatively easy to see even in a general OB ultrasound, but even those are like 2/3 presented or diagnosed prenatally, so still not great. Things like total anomalous pulmonary venous connections or venous returns, which is a fatal diagnosis if you don't repair it in the first couple days, less than 10% prenatal diagnosis. So unfortunately, in all but very specific views, this will look normal on a normal OB ultrasound. So a lot of these don't even make it to cardiology before birth. So that's part of the reason that the detection rate is so low. But there is quite a bit of a spectrum in how accurate we are. By area is also changing in accuracy. So here we are in Tennessee, 40 to 50%. That's where we are. That's where the rock is. Kind of upper normal at least, but there is quite a bit of variation even within the country too. Had to include this one because this one includes our previous speaker. So Dr. Woods was on this one when he was at Louisville, but it looked at prenatal diagnosis of critical congenital heart disease and then how that affected postnatal management and postnatal survival. And the key was prenatal versus postnatal. If you know the diagnosis beforehand, less of them die before surgery, as you might expect. So that's good. And the odds ratios all trended toward, yes, prenatal diagnosis is good. So not all things probably realistically affect it. Okay, they have a VSD. We know that prenatally. Is that realistically going to affect if they live or die? Probably not. But a lot of these ductal dependent things or things that need urgent surgery very much affect the outcomes, even just several hours earlier of intervention. So neonatal circulation. So now we're born, but we still have a couple of those things that are present in fetal circulation. So we have that PFO and that PDA, and that can definitely be present in those early, especially several hour-old neonates, despite being term or preterm. So all neonates have potential right to left shunts, and many of you have seen, DSATs intermittently, especially in these preterm infants that have those shunts. PDAs for us can be good and bad. They can help temporarily treat ductal-dependent congenital heart disease. So we'll talk about that later, but if you have severe obstruction to either the pulmonary or the systemic side, the PDA is your tool essentially to provide blood flow to the side that doesn't have it. So prostaglandins are the big treatment, and that can promote ductal patency, even if it closes later. So sometimes if there's a coarctation, for example, that presents later after the PDA is closed at home, providing a really good dose of prostaglandin can sometimes open that back up. So just because it's closed doesn't mean it's permanently closed. Apnea is the big side effect we look at, especially before transport and those kind of things. Sometimes decreased blood pressure, fever, and rash can other side effects. But the big side effect of life is usually worth those outcomes. Balloon septostomy is sometimes necessary. There are some cyanotic lesions like transposition that some centers will do this regardless of if they're doing well or not, just to provide some extra mixing. Not as commonly needed now, just with prenatal diagnosis and in the era of prostaglandin. This isn't quite needed as much, but it certainly is still needed in some lesions. So some major categories of congenital heart disease. There are the acyanotic non-obstructive lesions with a left to right shunt. There are acyanotic obstructive lesions with a left to right shunt. And then there's acyanotic lesions that everyone's worried about. So they have right to left shunts, and it's usually a combination of abnormalities. So there'll be some holes, there'll be some obstruction, there'll be a variety of different things, and we'll talk about those in more detail. So the acyanotic non-obstructive ones, which are thankfully the most common ones by far, include PDAs, ASDs, VSDs, and AV canals. So the PDA to start out with, we just talked about that briefly. So again, a connection between the aorta and the pulmonary artery, and the direction of flow kind of depends on pressures in either one of these. So for example, in pulmonary hypertension, it'll be right to left and cause cyanosis. In a, say, normal developing baby that's growing, it'll be all left to right and provide more pulmonary blood flow than necessary. The classic finding for your textbooks is a continuous machinery-like murmur, but basically anyone that's examined a newborn that has a PDA knows that's not exactly what it sounds like. So it's usually just a systolic murmur in neonates, especially early. It will largely be a pulsatile lesion and just be that systolic murmur. They can often have bounding pulses too. It can be useful in determining pulmonary artery pressure and resistance from our standpoint. So on echo, just using the direction and the velocity of that shunting can really give us an idea of the difference in pressures between systemic and pulmonary pressures. It can also hide coarctation of the aorta. So a coarctation often happens right where this PDA plugs in. So a lot of times, and we actually have a baby in the NICU right now that we're doing this, there'll be maybe some hints that there might be a coarc, but there's a big PDA right there. So you really can't see the whole vessel. And sometimes you just have to wait for this duct to close to either reveal what's going on or not reveal. There's been both ways that we think, ooh, that's gonna be a coarct, and the PDA closes and it's okay. And vice versa, that boy, it looks all right, but then the PDA closes, and unfortunately, there's actually ductal tissue all the way around this aorta. So sometimes the PDA closing actually shrinks that part of the aorta too, and then kind of reveals or causes a coarct as well. So you'll often see our reports early that cannot rule out coarctation in the presence of a sizable PDA, and that's exactly why. So over time, a PDA can cause too much pulmonary blood flow and cause pulmonary hypertension. So there are ways to close PDAs. In the NICU, we use different medications, Tylenol, ibuprofen, indomethacin. Later on, as an outpatient, you can close them with cath, and that's becoming more the first line in later life. You can do surgical ligation as well. But in the cath lab, what you do is basically go in through the legs, go into the right atrium, right ventricle, out the pulmonary artery, and basically cross that PDA and put either a little coil or device there, and that closes off that vessel. That little device stays there lifelong, and it's cured essentially. And that's a very high success procedure. And this is what it looks like in the cath lab. We're kind of injecting the aorta with contrast, and you can see this is where the PDA is, and there's kind of squirting into the pulmonary arteries. So if you put contrast into the aorta, you shouldn't see the pulmonary arteries light up as well. So basically they put that little device in and then they inject the aorta later. Device is blocking that and you don't see the pulmonary arteries in the background anymore. It's a nice successful closure. ASDs are next, so very common as well. So a defect between the top two chambers of the heart. There are a variety of types. So there's four main types. Secundums, or basically ones in the middle of that septum, are by far the most common. Primum are associated with AV canals. That's kind of the bottom part of the septum. Sinus venosus are less common, kind of the top part right where the SVC plugs in. And then coronary sinus are by far the least common and are exactly what that indicates, kind of right where the coronary sinus usually opens up into the right atrium. It's almost never an issue in neonatal life, especially these most common ones. Even pretty good sized ASDs are handled really well. Over time, like years and years, this can create pulmonary hypertension, but that's almost always in adults. We usually consider closing these at about 2 to 4 years old, kind of depends on the size. Some we just watch, but some, if they're kind of moderate to large in the 2 to 4 year age period, it's a good size that we can close it with a device as well. So most secundum common defects can be closed without surgery these days. This is actually an older device, an Amplatzer. This is a Gore, a newer device, and there's a couple newer devices that have come out even since this. That basically you go in same way as we were discussing through the PDA or for PDA closure through the IVC and into the right atrium, and basically you open one side, pull it against the septum, and then open the other side, and it kind of sandwiches it shut. Same thing. This stays in the heart and is a curative procedure and is very high rate of success as well. VSDs, technically by textbook, the most common congenital heart disease. A lot of these are probably missed in the muscular septum. So there's lots of different types. Membranous or kind of paramembranous are probably the most common we see, although a lot of these muscular ones may even close up, one, before delivery, or B, before they even see cardiology as an outpatient. So are realistically more common than membranous. Inlet VSDs are essentially AV canal defect VSDs, and then there's outlet VSDs, which can cause different problems as well. The severity depends on the size and location, and that kind of determines if there's obstruction by the nearby valve, if it can cause other issues, also if it's going to cause heart failure symptoms. They have a much higher gradient shunt than an ASD. So a same size ASD will cause much, much fewer issues than the same size VSD. So the difference in ventricular pressures are much higher. So there's just going to be a lot more shunting through that hole. And because of that, symptoms present much earlier. Usually not in early infancy, newborn period, but in infancy if it's a bigger defect. The large defects do occasionally need closure in infancy. The moderate to large ones almost always need repair in the first year of life, but sometimes you can have nearby valve tissue start to obstruct them or something, and it might be able to delay or completely avoid intervention as well. And they are almost always part of the spectrum of other more complex defects as well. And then we have complete AV canal defects. It's the combination of the two we were talking about. So big ASD, big VSD, and a common AV valve. So one big valve instead of two. And these are various types as well. This is a partial AV canal defect, which is essentially just a primum ASD, but it is technically part of the AV canal spectrum. And there are a variety of types in this spectrum. So you have that partial canal on one side that's just the primum ASD, and then you have a complete AV canal on the other side with a big ASD, big VSD, and common valve. Then in between, there's kind of intermediate and transitional canals. These two really act more like ASDs. These act more like VSDs in general. And the farther you go this way, these need repaired earlier than these. So as you probably know as well, these are very commonly associated with trisomy 21. If you have Down syndrome or trisomy 21, you have about a 40% chance of having an AV canal. And interestingly, the vice versa is also true. So if you have a canal, you have about a 40% chance of having trisomy 21. This is usually repaired around 3 to 4, sometimes up to 6 months of age. They can often present with heart failure symptoms prior to that and need either Lasix or afterload reduction. This is one of the ones that is becoming more frequently diagnosed in fetal life. Even that normal kind of 4-chamber view of the heart will look abnormal in an AV canal, so it's a relatively easy one to see. This is one that it is very helpful to know just for families. Realistically, may or may not change the outcome that much, but it is definitely helpful to know for planning before birth. Also, just to know if the baby has Down syndrome too. So moving on to the acyanotic obstructive congenital heart diseases. So these are basically the outflow things, problems with valves. So first, pulmonary valve stenosis, basically a thickened pulmonary valve here. And then there's aortic valve stenosis, which would be this valve abnormal. And that's almost always due to a bicuspid aortic valve. So normally 3 cusps, and it's basically 2 are fused. So it kind of opens like a fish mouth and doesn't open or close sometimes appropriately. So there's usually a pretty significant systolic murmur if this is going to be a significant outflow obstruction as well. Presentation also depends on severity. So if it's mild A or PS, they may present much later in life. Aortic stenosis is handled more poorly. Basically anything on the left side of the heart is going to be handled much more poorly than something on the right side of the heart. And then severe or critical aortic or pulmonary stenosis can present soon after birth. And this is actually another incidence where prostaglandins can help. So if you have really, really bad outflow obstruction from either aortic or pulmonary stenosis, if you do prostaglandins, that will help provide blood flow to the other side. So if you have aortic stenosis that is so severe that barely any blood flow is getting out, if you start prostaglandins and open up that PDA, then they'll be right to left shunting and provide blood flow to the systemic circulation that the aorta is not doing. So that can help in that case. Balloon dilation in the cath lab is often the first step for these. So this is another instance where they may or may not need surgery. And they basically put a balloon in that valve, inflate it, and kind of create a controlled tear, and then deflate the balloon and take it out. And that often relieves at least enough of that stenosis that they do okay. Sometimes that can be a one and done procedure too. So sometimes they may or may not ever need anything else done the rest of their life. Coarctation of the aorta is another obstructive lesion that we've, for some reason or another, seen a lot of in Chattanooga. So it's a narrowing of that aorta, almost always right around where that PDA was, as we talked about. It can occur in other places, but this is by far the most common location. So, like I said, happens at or near the PDA. Prostaglandin is indicated for sure with a significant coarct. And then, just like we talked about, sometimes you have to allow that PDA to close or nearly close to fully evaluate it. So if you know about it and you're kind of watching it in the NICU and you're doing relatively frequent echoes to kind of see what that looks like as the PDA closes, if it gets nearly closed and it looks like, ooh, that coarctation is going to be significant, you just start prostaglandins, the PDA gets bigger, and you're good. How these kids get into trouble is if we don't know about it, they go home and then they present in 9 to 10 days of life, and the PDA is already closed and they're not getting much systemic blood flow at all, and those babies can present really, really sick. So early monitoring, we look at upper and lower blood pressures, we look at saturations as well, and pulses are important. These are not usually amenable to cath lab intervention, at least for first surgery. So they usually basically take out that part that is narrowed and basically connect the two. There's a couple of variations on that surgical technique, but it's essentially just an end-to-end anastomosis. They can have cath interventions later in life. So as you might imagine, if you do surgery on a vessel in a newborn, it can re-narrow. So you're going to have some suture lines around there. There's some scarring that can happen. So not uncommon, especially if you need to do surgery in the first days of life, that they have recoarctation down the line. So not uncommon that 2 to 3 months later, you have to send them back to the cath lab. Then they can do a balloon, just dilate that area. And then that part usually lasts for years and years and years. And then cyanotic congenital heart disease. So these get more complicated. So there's tetralogy of Fallot. Have a question?
She muted.
Okay. We have tetralogy of Fallot. We have transposition of the great arteries, pulmonary atresia with intact ventricular septum, truncus, total anomalous pulmonary venous connections or hypoplasts, We'll go over some of these. So tetralogy of Fallot. So most of you know that there's kind of 4 defects-ish that are associated with this. So you have a VSD, you have an overriding aorta, then you have pulmonary stenosis, and then RVH, or right ventricular hypertrophy. It's actually all from one problem in fetal life, that basically this part moves anteriorly and superiorly during development. And simplistically, it basically brings the aorta with it, so it makes it override. It causes that VSD to form, and then it basically pinches the pulmonary outflow tract and causes pulmonary stenosis. So it's really just movement of this part of the tissue that causes all of those things, and then the RVH developed because of the pulmonary stenosis. The severity is determined by the pulmonary stenosis. It's not determined by size of the VSD, which is almost always large and unrestrictive in a tetralogy. It's all about how bad the pulmonary stenosis is. So they may or may not be cyanotic early. If it's really bad pulmonary stenosis or nearly critical, they are going to be cyanotic nearly right off the bat. If it's pretty mild, they may be fine for months or longer. It also includes a variety of defects. So there's some variations within tetralogy of Fallot. So the most severe form would be tetralogy with pulmonary atresia, or some people just call this pulmonary atresia with a VSD. But the kind of critical pulmonary stenosis or pulmonary atresia is treated essentially the exact same way. There's tetralogy with an absent pulmonary valve, which is very rare but can cause really, really dilated pulmonary arteries, and you do treat differently. Tetralogy can actually occur in combination with an AV canal, also still associated with Down syndrome. And then tetralogy can be associated with double outlet right ventricle. You can imagine sometimes if this really overrides, then both of them can be committed to the right ventricle. That one is largely semantics, to be honest, and you end up treating it exactly the same as kind of a garden variety tetralogy of Fallot. And then surgical timing and type and different interventions are based on the severity of pulmonary stenosis. Transposition of the great arteries. So this is one that is unfortunately not highly diagnosed prenatally because if you look at just a 4-chamber view of the heart, it looks completely normal. And you really have to get good views of these outflow tracts and see where they're going to determine if it's transposition. So these will look cyanotic early, because basically they're parallel circulations. So blood comes from the body and goes to the body and then back. Vice versa, blood comes back from the lungs to the left side and goes back to the lungs. So nothing's crossing. So if you have a PDA, that can help somewhat, although unfortunately it's going to end up being blue blood to red blood, because since this is going to the body, it's higher pressure. So if you have a PDA here, it actually ends up just getting blue blood to red blood, not vice versa. With an ASD, this is actually the best way to do it. So this is one of those lesions where an atrial septostomy or enlarging this ASD can help, and actually need some sort of atrial defect, whether it's a PFO or ASD, to survive at all. So with blood coming back to the left side, the pulmonary veins can be a little higher pressure and pushes blood flow that is red blood now going to the body, or at least mixed blood flow. That, interestingly, can be the only purpose of a PDA, is causing higher pulmonary pressures by causing kind of systemic to pulmonary flow, and in turn causing higher left atrial pressures and causing more atrial flow. So you're getting red blood to the body. So these are usually born blue, and this is classically comfortable cyanosis because there's not too much blood flow anywhere. There's a normal amount, it's just not going the right places. So they're blue, but they're not breathing harder or anything like that. Like we talked about, they can be missed on prenatal imaging. Like we talked about, prostaglandin can help mixing, but they really need an atrial septostomy or just doing their repair early. So some, if they know about it early, you might be able to skip the atrial septostomy and just go to repair sometime in that first day or 2 of life. They do often need intervention sooner than later. These are not ones you set on for weeks on end. These are the ones definitely within the first week of life, but often within the first days they need repair. After repair, they actually do really well. So the repair nowadays just largely consists of what's called an arterial switch. So even though it sounds simple, they just swap the pulmonary and the aorta, and now they're going to the right places. This also involves moving the coronary arteries, which are now connected to the pulmonary here. So that's the difficult part. They used to actually just baffle things in the atria. So they would baffle, so the right-sided deoxygenated blood would actually go to the left side, and then vice versa. There's all kinds of problems with those baffles and issues with abnormal rhythms down the line. We don't really do that anymore. And the surgery we do now is very high success and pretty low need for a repeat intervention down the line. Pulmonary atresia with intact septum. So this is kind of a unique heart disease that there's pulmonary atresia just like the severe form of tetralogy of Fallot, but instead of having that VSD, you have an intact septum. So there's no place for blood to go, again, unless you have an ASD. So you kind of have to have an ASD as a pop-off valve. And this is when you do need a PDA, because if you don't have a PDA here, there's no way for blood flow to get to the lungs. So this provides systemic blood flow to the lungs to provide a little extra flow. These can be blue at birth as well. Prostaglandin is needed to provide pulmonary blood flow, as we mentioned. These can be a complicated repair strategy. So if this right ventricle is formed enough, and this is sometimes what we call membranous pulmonary atresia, that it kind of looks like there was supposed to be a valve there, but it just never opened. Sometimes you can do something as simple as basically pop that open in the cath lab and provide pulmonary blood flow. Sometimes it looks more like this, that there's kind of this big muscle band there that restricts all pulmonary blood flow. You can't just pop through that in the cath lab, so that requires surgery. Then they also can have coronary abnormalities and have a high incidence of sudden death. So the coronary abnormalities can be these what's called right ventricular dependent coronaries that are actually dependent on high pressure in this chamber, but they'll have these little connections to the right ventricle. And on echo, it has this what we call a heart on fire look, that there's basically a little flow all throughout this ventricle in the walls, not in the ventricle itself. And unfortunately, what happens if you don't see that and you decide, oh, I think that's an adequate sized ventricle, and you open this up and relieve the pressure, they essentially have a heart attack because of now the pressure is dropped in here, those coronaries were dependent on it, and all the coronary flow reverses, and you have ischemia. So we don't want that. So sometimes you can have that, and you do diagnose it. We had one that we could even see prenatally that there was so much flow in that ventricle, and you have to do a single ventricle repair, which we'll talk about, and just use this one and kind of leave that one be. Truncus Arteriosus is a big VSD and then one outflow tract. So there's one big truncal valve that is always an abnormal valve. And then from that spot can go the pulmonary arteries or the aorta. These are relatively rare. Sometimes they have early cyanosis, sometimes not. There's no need for prostaglandin here because they have plenty of blood flow to both. These can quickly develop pulmonary vascular disease because there's so much extra pulmonary blood flow, because basically all the blood from both the left and right ventricles, as the pulmonary resistance drops, can go right to the lungs, just because there's unrestricted blood flow there. It's basically a combination of a huge VSD and a huge PDA, except with just sudden mixing of both. The truncal valve, like we said, is almost always abnormal. These almost always need early repair, and it can be a complicated repair as far as how you separate those two circulations. They usually need a conduit from the right ventricle to pulmonary arteries and then kind of disconnect this part. Knowing what to do with this valve is tough, so often they need it repaired a bit. It can have 2, 3, 4, sometimes 5 cusps. And often leaks and valve repairs and systemic valves are really tough prenatally or in newborn period, I'm sorry. So sometimes this can cause frequent issues even after initial repair. Total anomalous pulmonary veins. So this is a little tough to see on this picture, but the main takeaway is everything is blue. So pulmonary veins usually come back, from the lungs to the left side of the heart and drain into the left atrium. What happens in total anomalous pulmonary veins is they usually get to behind the left atrium, but then that connection never really developed, or that kind of posterior atrium never really resorbed, and the pulmonary veins go someplace else. So in fetal life, there's always what's called a vertical vein that usually kind of dissolves and goes away. But in this case of supracardiac pulmonary venous return, that stays open. So blood comes back from the lungs, tries to go to the left atrium, but it can't, so it goes north, and then it ends up going back to the SVC. That can be okay if there's no obstruction in this vessel and there's a good size ASD. If there's obstruction anywhere, it becomes really bad. So this is a different diagram showing that supracardiac as well. This is kind of more what it looks like, as far as you'll see those pulmonary veins come back, but then they'll all have this vertical vein and then connect to the innominate vein and SVC. This is infracardiac or a subdiaphragmatic total pulmonary venous return. Same thing, they'll initially come back where they're supposed to, but then never get to the left atrium. And these go south or inferior through the liver actually, and then into the IVC. These are always obstructed, the infradiaphragmatic. The supracardiacs may or may not be obstructed initially early. So if they are obstructed, meaning there's difficulty for venous flow to get out of the lungs, they are cyanotic and very ill appearing because there's no place for blood to go. They have whiteout lungs on x-ray. Prostaglandin does not help in that you don't need extra blood flow anywhere. If you have extra blood flow to the lungs, would be bad. Sometimes it can serve as a pop-off if it's misdiagnosed early, meaning there's all this blood flow to the lungs that has no place to go. So the PDA can sometimes provide a little off-flow as there's pulmonary hypertension develops. But in general, it doesn't really help. It is a difficult prenatal diagnosis because pulmonary veins are tough to see and the rest of the heart looks normal. So these are ones, unfortunately, that can be super dangerous early, yet not diagnosed prenatally. So this is one that everyone's worried about. They need urgent repair as well. There's really not much you can do short of just fixing them. One of the common things is you don't let the sun rise or set on total anomalous pulmonary veins. So they get repaired that day if you can. Hypoplastic left heart. So this is a combination of anomalies, usually two. This is actually a pretty generous left heart from what we usually see. So usually it's a combination of mitral and aortic, either atresia or stenosis. Kind of the classic one is atresia of both. So there'll be this kind of barely a little nugget of a left ventricle and just a right ventricle. And it will have a very hypoplastic or small ascending aorta, but then usually the aorta kind of gets to normal size after the ductus. So these need prostaglandins as well, but for systemic flow. So here you're using prostaglandins to provide blood flow to the body. And in this case of these really small aortas, the blood flow actually goes both ways. So blood will come out of the PDA and actually go backwards to the ascending aorta and fill the coronaries and go to the body too. So they definitely need a duct of some sort. Atrial septostomy can help in these as well, provide extra blood flow. As you imagine, if there's barely any shunt here and there's mitral atresia, kind of same thing as like total veins, there's no place for blood to go from the lungs. So you need blood flow both to get out the lungs, and that's the only way for red blood to get to the body. So you need a wide open atrial communication. And that's one of the things we do look at prenatally for hypoplasts, is to see if they have a restrictive atrial septum. And that is one of the big determinants of kind of how well they do or how early they're going to need repair. These are often diagnosed in utero, thankfully, not always. We have seen a hypoplast present to our ER that was undiagnosed prenatally and postnatally and just presented after they got really sick. But thankfully, there's really not any view in which you can make the heart look normal on a prenatal ultrasound, so it shouldn't be missed. And these are a single ventricle repair, which we'll go over. And a lot of lesions like that, pulmonary atresia, intact septum, sometimes pulmonary atresia, even with a VSD, can go through this same process. Tricuspid atresia would be another one. So in general, this is what we call a single ventricle pathway looks like. So initially, there's going to be a small ascending aorta, like we talked about, and then a normal pulmonary artery. And what they do initially is they actually connect those two and make one neo-aorta. And so this is kind of a combination of those two vessels. They disconnect the pulmonary artery, but then they need to still get blood flow to that. And then historically, they did this, which is called a BT shunt, or Blalock-Taussig, or if you're really correct, Blalock-Taussig-Thomas shunt. And then a Sano is more of a almost conduit, goes from the right ventricle to the pulmonary artery. Some surgeons have different preferences. These are a little easier to manage later. These are a little easier to manage early, but they're kind of putting a scar on the ventricle, so they have rhythm issues later. Some now are actually just stenting the PDA. So if you have a good sized PDA in the right spot, that is also an option rather than providing another conduit. But basically, this is all the blood flow from the lungs and from the body comes in and goes to the right ventricle and then goes out to here and then can go either to the lungs or to the body. So there's a balance of how big this is too. You don't want too high of saturations. That means too much blood's going to the lungs at the expense of the body. Vice versa, if you have very low saturations, too much is going to the body at the expense of the lungs. So we often like sats kind of 75 to 85 in this stage for balanced blood flow. These don't grow with you, however. So eventually you'll become more cyanotic as less and less blood flow goes to the lungs as you grow. So the next stage is called a Glenn, or a bidirectional cavopulmonary anastomosis. And this usually happens somewhere around 4 to 6 months old. And what we do is, we the surgeons do, is plug the SVC into the pulmonary artery and take away whatever shunt you had. So the BT shunt or the Sano is taken down at this phase. And we've all seen babies and they have larger heads than most of us in comparison to the rest of their bodies. So there's actually a good amount of blood flow that just comes from head and arms and neck to the lungs, and this provides all your pulmonary blood flow. You're still having desaturated blood coming from the lower part of the body, so you're still not having normal sats with this circulation, but it does kind of offload the heart that not all of the blood is coming back, and it's responsible for pumping all of it out. The sats are usually low 80s probably for a Glenn. This also doesn't last forever, and as kids grow, they'll become more and more cyanotic again, kind of as they become more proportional too. And then the final phase is called a Fontan, and this has undergone several permutations over the years. They used to just use the atrium as part of this conduit, and then that would get really big over time. Now they mainly do this, which is called an extracardiac Fontan, which is essentially a tube connecting the IVC to the lungs as well. So now you have all passive flow from the body going directly to the lungs. Blood gets oxygen, comes back to the lungs, and then goes to the body. So heart is now pumping just to the body, and nothing is pumping to the lungs. As you might imagine, you have to have really good lungs for this to work, as far as you can't have any element of pulmonary hypertension or high vascular resistance at all. These kids can have liver problems over time because there's congestion of non-pulsatile blood coming out. There are a set of issues that come with this for sure, but then a lot of kids actually do great. And we've even managed 30-some-year-olds that have had 3 pregnancies successfully that had a Fontan. So there's people that do really well with this as well. And there are still multiple others that we're not going to go over. So there's tricuspid atresia that will undergo primarily that single ventricle pathway that we talked about too, except they have a left ventricle instead of a right ventricle. And they actually do a little better because the left ventricle is actually designed to pump to the body over long term. Ebstein anomaly is a severe malformation of the tricuspid valve. Schoen's complex is a combination of usually a coarct, a bicuspid aortic valve, and an abnormal mitral valve. There's intracardiac tumors we see. There's an AP window that's basically equivalent to an enormous PDA. There's interrupted aortic arch, which is basically the most severe form of coarctation. There's portratriatum, which can act like total veins. There's congenitally corrected transposition. There's a variety of different combinations. We can't go through all of them, but there is basically any way you can imagine the heart coming out wrong, it can come out wrong. So when do you refer an infant? So early on, murmurs at birth, like right after birth, usually warrant referral at some point. If it's 3 or 6 or greater, so definitely if they have a thrill, definitely need referral, but loud persistent murmurs probably do. If there's ever murmur plus symptoms, yes. So if it's ever just isolated murmur, but they're otherwise doing fantastic, you could hold off. It's never wrong to refer, but definitely murmur plus symptoms, we need to see them. Central cyanosis, so cyanosis of kind of the chest, and then the mucous membranes especially, definitely send sooner than later. Increased work of breathing with feeding is usually the first kind of cardiac symptom we see in newborns, often from kind of heart failure symptoms due to like large VSDs, for example. And then poor pulses, obviously. And that's something that is very key to watch for, especially in these coarcts that were missed early. As you also probably know, just because you have a murmur does not mean you have a heart disease. So we have lots of benign murmurs out there. But also the converse is true, that just because you don't have a murmur doesn't mean you have a normal heart. So some of those things like transposition or total veins, which are some of the most dangerous early heart diseases, will not have murmurs. So they'll actually have a pretty normal cardiac exam. So just because you don't hear a murmur and there's other concerns does not mean that there's a normal heart. So in summary, babies with congenital heart disease need specialized treatment, both pre and post delivery. If you have basic knowledge of the defect and the physiology, it can greatly aid care. And then all members of the medical team can assist with diagnosis. So a lot of times, especially in newborn nursery, it's a nurse hearing that murmur, or it's somebody else hearing that murmur first, and that is completely fine. And we've diagnosed a lot of things just based on somebody else hearing something or seeing something concerning. So that is a whirlwind of most common congenital heart diseases. I will open it up to questions. Can I see that?
Yeah, just hover over that top part, yeah, and then more.
I'm not seeing it. Do I have to exit out of this?
We got a comment, presentation was awesome, thank you.
So you can see the chat?
I can see
Okay,
it.
that's good. Hopefully helpful. And we're obviously willing to see kids before or after birth, whenever. We have a close relationship with the maternal fetal medicine here. For some reason, how it is in Chattanooga, it seems like people go to MFM first and then us. But regardless, yeah, happy to see anybody whenever. And usually we can get them in pretty quickly too. There's 3 of us and we can always get them in quickly if we need to.
Thank you and good information.
Right. All right, sounds good. Thank you.
Thank you so much.
If y'all will take 5 minutes, we will get the next presenter ready to go.